Good morning, everyone. Again, welcome to this YouTube channel, Pain Free Partha. Welcome you all again to my website also, www.painfreeparthas.com for free downloadable sites. Now, our topic today is about clonidine. So, whether this drug is going off or on, out or in is slightly there. So, greetings always from my institute, Mahatma Gandhi Medical College and Sri Balaji Vidyapeeth University, Pondicherry. How was it discovered? They called Dr. Wolf and administered himself onto his secretary, whether he know no male or female secretary, administered few drops of clonidine as for decongestion properties to the nose. But accidentally they found, or what you call as in high profile English, you can call it serendipitously or by chance. They found it to be bradycardic. BP was falling and some sedation. So they thought it could be a better antihypertensive rather than the so-called nasal decongestant. So this is the clonidine structure. It is an imidazoline derivative, similar to tolazoline. The alpha receptor 2:1 is this, is slightly less than that of dexmet. Clonidine and norepinephrine are similar in shape. Now I wanted you all to focus on this. This is alpha receptor and beta receptor. We will concentrate alpha 1, alpha 2, beta 1, beta 2. Alpha 1 is present in the vascular structure, stimulate vasoconstriction. Alpha 2 is somewhere here, stimulation, BP will fall. Beta 1 is in the heart, inotropy, chronotropy. Beta 2 is in the smooth muscles, bronchodilation, uterine muscle relaxation. So now you see adrenaline is going to act on alpha 1, alpha 2, beta 1, beta 2 here. Now ephedrine is more in alpha 1, beta 1 and beta 2. Not much as a specific alpha 2. Now you see noradrenaline, it doesn't act on beta 2. It's more of an alpha 1, alpha 2 and some sort of beta 1. So alpha 1 is predominant with noradrenaline. See, there may be some action in beta 3. Now this terbutalin, salbutamol, formoterol, all these drugs are acting on beta 2. That is what is bronchodilation. Now isoprenaline is not near alpha. It is only beta 1, beta 2, beta 3. So this is a powerful chronotropy. That is why refractory bradycardia, after atropine we go to isoprenaline, then we go to temporary pacing. So this is how isoprenaline is mainly beta 1, beta 2. Now we go to oxymetazoline where we put on drops. That is not acting on beta. That is more on alpha and alpha 2. Now phenylephrine, that's what I told you, ephedrine and phenylephrine. It is more on alpha 1. This causes less of tachycardia, not much in alpha 2. So that is the advantage of phenylephrine. Now we have clonidine, dexmet, all these things acting on alpha 2. Alpha 2 means BP falls. All other things different. Alpha 2 decreases central sympathetic drive. That is what is very important. Adrenergic agonist that causes BP to fall. That is very important to note. Dopamine is beta 1, beta 2. So that is why some inotropy with some sort of vasodilatation and decreased afterload. Dopamine, we can see here, all these things are available. Beta 1 and alpha 1. So what we are going to check about it is about alpha 2 stimulant, clonidine. What are the routes of administration of clonidine? Oral, IV, even IM is used. Nebulized clonidine, nerve blocks, spinal, epidural, transdermal. So many routes of administration of clonidine is there. If you give IV, the action is peaking in 10 minutes and it may be acting up to 4 to 5 hours. Oral initially was used as an antihypertensive, cataprast. That was the drug used. Good reduction of BV and excreting via urine after liver metabolism. This was an antihypertensive long back. Clonidine. Now we know that it is stimulating alpha, central sympathetic drive is decreased, so BP falls, there is a sedation, all these things. There is a pulse rate fall. But is this the only mechanism? Decreased sympathetic drive and decreased noradrenaline. Yes, there may be a reduction of upward thalamic transmission. There may be locus coeruleus induced hypotension, vagal nucleus, cholinergic, purinergic analgesia, aldosterone, interaction with opioid receptors. What all these means, probably we are not very clear about the clear-cut action of clonidine. Probably alpha-2 stimulant, central sympathetic drive decreases, analgesia, sedation, and bradycardia. Hypotension. Neuraxial clonidine. How does it act? Okay, now we have given IV, IM, oral. All these things act. How does it act if you give into the spinal? If there is a stimulation, there is a presence of alpha 2 receptors in the dorsal horn. So it stimulates this. So thereby it causes antinociception, increased acetylcholine, cholinergic mechanisms. That is what neostigmine was used previously. Intrathecal neostigmine producing good analgesia. All these things. After vomiting came, it went out. Intrinsic blockade of these receptors, A delta and C. A delta is first pain, C is second pain. Local vasoconstriction. Yes, now, the first additive to bupivacaine, lignocaine, all these things was adrenaline, no, spinal. So that is an alpha agonist. So that is also a part of action of this clonidine. Suppresses the generation of action potentials, potassium channels, and hyperpolarization. So all these things are possible mechanisms of neuraxial clonidine. So now we know it is an imidazoline derivative. It was found out accidentally by NASA as a nasal decongestant and came like this. And it is mainly on alpha 2 receptors in the central sympathetic drive is decreased. So there may be some alpha 2 receptors in the dorsal horn also. The analgesic action may also be due to potassium channels, due to opioid, due to interaction with opioids, due to neostigmine-like action, due to locus coeruleus. All these things may be there. So BP fall, sedation, bradycardia, analgesia. The peripheral effects are to the inhibition. In nerve blocks, what happens? Hyperpolarization. The current normally functions nerves again go to a resting potential. This is blocked. So hyperpolarized state it is there. The effect appears to be more profound on C fibers than A delta. They are more sensory specific. Now what happens to the CVS? Yes, in the supine position, it reduces MAP by 10 to 15%, average of 17% they see. Cardiac output decreases, heart rate decreases, stroke volume decreases. Automatically it decreases. Heart rate into stroke volume is cardiac output. Heart rate decreases, stroke volume decreases, it has to decrease. There is no change in TPR. So vasodilatation is not important. So vasodilatation important na diastolic blood pressure. So cardiac output means it's systolic. So the decrease in systolic BP is more consistent than diastolic BP when you say cardiovascular effect of clonidine. So there may be, if you give IV, there may be an initial alpha 1. So there may be an initial BP rise. But that is very transient and insignificant. The alpha 2 agonist have minimal depressant effect on ventilation. Do not put it. So there is not much of problem with your respiratory depression at all. There may be sodium and water retention and there may be dry mouth. All these are very minimal. These actions are very minimal. What are the clinical uses? Now we know analgesia, sedation, hypotension, bradycardia. What are the clinical uses? Now it is causing an hypotension means we can use it for intubation response. We can use it for perioperative ischemia probably. We can use it for decreased anesthesia requirements because it's a sedative. The maximum effect occurs at 15 minutes. So when to time it, that is very important. So if you give clonidine and start giving propofol again, there is not much of difference. So if you are planning clonidine, give clonidine IV a little 10 to 15 minutes prior, wait for it to act, and then use your propofol or agent. Then there is a reduction. Reduction in standard MAC and MAC for intubation after clonidine epidemic. Effect of clonidine. Yes. probable reduction of MAC by 25% and probable propofol requirements decreased by 20%. Now, efficacy of clonidine for prevention of ischemia. Advantages over why. See, for example, now if you want your ischemia to be decreased or intubation response to be decreased, but this patient has got some amount of bronchospasm or reactive airways where you don't want beta blockers. Because are preferable for reduction of ischemia. So in this case, we can try this clonidine. Transdermal patch for 24 hours, 0.1 milligram, may be used for 7 days. This is only drug which can be used as oral, intravenous, transdermal, IV, epidural, spinal, everything. Clonidine decreased anesthesia requirements but does not delay recovery. Decreased postoperative oxygen requirements. Decreased postoperative shivering. I will say this is one of the most important use of clonidine. You start using this, just give 25 mics IV prior to induction. The shivering is very less. Or even if you use for spinal anesthesia, 10 mics or 15 mics of clonidine, it decreases the incidence of shivering. Hypertensive emergencies, an initial oral dose of clonidine followed by hourly doses. A total, see here, oral dose in hypertensive emergency, clonidine hydrochloride. In neurosurgery, it produces optimal hemodynamic stability, good heart rate, MEAP, ideal dural tightness. We can use it oral clonidine for ophthal anesthesia. Intravenous clonidine as a part of balanced anesthesia for controlled hypotension in FES. What they have used is up to 3 mics, 30 minutes prior to induction of anesthesia. 3 mics means how much? 60 kg is 180 mics. Normally, one ampule will contain 150 mics. Regional anesthesia and intravenous clonidine prolongs bupivacaine spinal anesthesia. Both, yes, and 30 mics and 60 mics are useful. This is a very interesting thing, but why it should come like this, I don't know. But if you give clonidine before the spinal anesthesia gets fixed, 30 mics of clonidine IV, definitely the block is better. I have used in almost more than 500 cases, out of which 400 cases are around LSCS, cesarean sections. I have found one case of fetal bradycardia in 30 mics. So there is one case, and that patient recovered normally, baby. Almost very minimal in these 400 to 500 cases of clonidine IV in LSCS patients. Even a small microbes increases spinal anesthesia. 15 mics. Traditional dose I use up to 30 mics, and people have used 150 mics also. 1 mic per kg in epidurals, even 3 mics per kg is used. 6 hours. 1 mic per kg per hour infusion in epidurals. So 50 mics epidural infusion 1 hour. There are variable results, and the biggest advantage is we can use fentanyl and then we can use again clonidine next time. That is one advantage, because both are different drugs. It acts through opioid, it acts through alpha 2. So that is also possible. But all these studies are mostly relatively going off the line. So 2020-22 are slightly coming, very less studies. Careful in the elderly. I find if it is going to be 75, 80 years, I am very this thing about using this clonidine in the intrathecal space, because it produces bradycardia little late also, because we have found in our study that this clonidine induced bradycardia may be there for around 30 to 40 minutes. So if your surgeon is going to finish the surgery within 30 minutes, then we need to be there for some time to see whether this clonidine acts for 40 to 45 minutes, causing bradycardia. That is very important. We have to be there along with the patient. That is one problem with clonidine if the surgeon is very fast. Perineural clonidine reduces mechanical hypophysis. See here, established nerve injury. Yes, they have used perineural clonidine. Brachial plexus block. Yes, there are a lot of doubts There are some studies for pro and some studies for con also, or they're not much useful, is also there. Intra-articular chlorine also producing conflicting results. But the problem is here it causes orthostatic hypotension. So fainting may be there, sedation may be there. So they may delay ambulation. So in patients who want to go home immediately, think about chlorine. Clonidine is a prototype of alpha agonist as an analgesedative in ICU care used in tetanus patients 100 mg per hour. And this is almost going out because of the entry of dexmet. Hypo, late brady, and withdrawal rebound hypertension, arrival of dexmet, query sedation in ICU. Intrathecal clonidine 150 mg decreases capsaicin and induced hyperalgesia. Hyperalgesia is what? Algesia means pain. Hyperalgesia is increased. Even 750 mg are used with side effects. Many chronic pain components where neuropathic component is predominant. Clonidine infusion through implantable pumps. Topical clonidine gel. Diabetic neuropathy. So this is about neuropathic pain. There are a lot of indications we can see from the beginning. Possible uses of say chronic low back, thoracotomy pain, neuropathic pain. Still lacks good clinical trials. So there are a lot of other uses. We can use in migraine, menopausal fishing, shivering, opioid addictions, anxiety, alcohol withdrawal. Diagnosis of pheochromocytoma, failure of the clonidine suppression test. It uses in pediatrics. Clonidine is 4 mg per kg orally, intranasally. Atropine, if you give, it decreases the side effects. A continuous infusion of 0.2% ropivacaine with clonidine or 0.2 mg per kg per hour, a sciatic nerve catheter. See, everywhere it is used. Pediatrics decreased demand. They have found out the emergence agitation, which is very tricky in these pediatric cases. We can use this cheap drug, clonidine, to decrease the emergence agitation. Better recovery in CTBS. Oral and clonidal clonidine causes decreased in postoperative nausea, decreased shivering. All these things are good in pediatrics. Emergence agitation, vomiting, shivering. This is what we are striking by way of clonidine. Beware if there is hypovolemia, if there is an AV block or prolonged PR interval, or if there is a spontaneous bradycardia. Beware of using clonidine. Cautious use. Gastric lavage, fluids, vasopressors. Clonidine overdosage. But tolazoline 10 mg IV every 30 minutes is the treatment of choice. Clonidine overdose. There is one drug called mevaserol, another alpha-2 agonist that is administered by continuous infusion. It has not become market hit so far because it is found inferior to dexmet in hemodynamic stability. Now, structure is by imidazoline derivative close to noradrenaline, routes oral, intravascular, intravenous, or even intramuscular. We can use epidural, caudal, or spinal, transdermal patches. Everything is there. Mechanism predominantly alpha 2 agonism. Alpha 2 agonism. This is the only catecholamine or alpha agonist which causes BP to fall. What are the effects? Analgesia, sedation, bradycardia, hypotension. Other uses, pre-medication, decreased pressor response, decreased propofol requirements, decreased inhalational agent requirements, better recovery profile, some sort of post-operative pain relief. All these things are there. There are other uses in chronic pain. There are other additives, neuraxial, epidural, in plexus. Side effects, again I'm telling you, BP fall, sedation, or you can use it as an advantage. Contraindications are very minimal. I am very particular about elderly patients. Toxicity, we know, vasopressors, IV fluids, and tolazoline. I will say the only use after the advent of your dexmet is this is only 20 rupees and dexmet is 450 rupees. And we don't need to use a pump. If you're careful, if your finger is good in titrating the dose, along with your cash, very calculative vigilance of the patient, yes, we can use this drug instead of dexmedetomidine. Thank you very much and welcome to www.painfreepartha.com and my YouTube channel, Pain